Good evening. I want to welcome you all to the Adrenal Insufficiency Starter Pack, Basics for Newly Diagnosed Families and Monitoring Phase Families. Welcome to this first ALD Connect webinar of the new year, 2024. I'm Kathleen O'Sullivan-Fortin. I'm one of the co-founders of ALD Connect and honored to be on the board of directors. And I'm really honored to be here tonight with Dr. Shah and with Sophia Rowland to really lead us through these discussions, questions that come up all the time on our support calls, online, in person at meetings. There are just so many tricky things and nuanced things that we need to understand about the adrenal insufficiency component of ALD. And so I'm just so grateful that we can all be here together. Before we get started with the good stuff, I just want to remind everyone that this webinar is for informational purposes only. It's not intended to be a direct diagnosis. It's not intended to change any direct medical advice that you've received from your own caregivers. It's really just supposed to start the discussion and then take, some of the things will sound similar to what is happening in your lives. And I say, write those things down and take note. Some of the things may sound different. My advice, and I'll say this again at the end, but my advice is to take these questions, concerns, points of interest, and take them back to your own treatment team so that you can decide truly what is best for your adrenally insufficient loved one. So with that, this webinar is going to hopefully answer all the questions, but understanding that we can't get to we can't answer every single question in the next hour, but we're going to do our best to get to everything. And again, ALD Connect does not recommend or endorse any specific physicians, treatments, procedures, products, or treatment centers, although they may and will certainly be mentioned during this webinar. But really, again, thank you so much for taking time on this January night to come together to discuss this very important issue. It's close to my heart because my son was diagnosed many years ago, 15 years ago, with adrenal insufficiency first. So I am so pleased that we're able to offer this. I'm going to turn things over to Dr. Sejal Shah from Stanford and let her kick things off. Welcome.
Thank you, Kathleen, and appreciate the invitation. And I'm really excited to engage with everyone. And this is a topic that is dear to my heart in terms of what I do day to day in my clinical practice. So it's a really wonderful experience, and I appreciate everything ALD Connect is doing for the community. I am a pediatric endocrinologist at Stanford, and as being an endocrinologist, adrenal gland changes, differences is part of what we do day to day. And we see children with adrenal insufficiency for a variety of reasons as part of our bread and butter, if you will, of pediatric endocrinology. So this is something that we train for, and this is what is part of our what we do day to day. So we really love to engage with families. So I will share my screen and we'll get started. So I have three main objectives for my part of the session today. The first is for you to hopefully understand the role of the adrenal gland and how the adrenal gland is affected in ALD. Understand a little bit about how the adrenal gland is affected and how it's evaluated. And then finally, a little bit about how adrenal insufficiency is treated. And as Kathleen mentioned, there's a lot of variation and everything really is patient specific, but I hope with this part of the session, talk a little bit about the why behind the what as far as recommendations and standards of care guidance that is available. So the adrenal gland is located just above the kidneys. There are two of them, and they have four main zones. And each of these zones are responsible for making hormones. Hormones are signals that our body uses for one part to communicate with another part. The specific part of the adrenal gland called the adrenal cortex is what is affected in ALD, and these changes can start in the fetal adrenal gland. Our body is reliant on our adrenal gland to be working typically because it needs cortisol for day-to-day needs, and then extra cortisol during times of stress, which we will talk about. The adrenal gland is under the control of the pituitary, so the part of the brain that controls many of our hormone signals. And this control is by a hormone called ACTH. So the pituitary gland releases ACTH and the adrenal gland responds to it. So the ACTH is a really good marker of how well the adrenal gland is listening to the signals that the body is sending it. Cortisol is what is produced by the adrenal gland, and it's got many roles, but most importantly is to help maintain the body's blood sugar level, which is the body's fuel. The brain runs on glucose, and it helps keep the blood pressure up, and this allows for blood to be pumped to vital organs like the brain and the heart. The adrenal gland also makes a few other hormones, which we'll briefly mention here, but you may hear about over time. One are mineralocorticoids. These are hormones that have a role in keeping our salt levels normal. Androgens, these are helpful for pubertal changes in secondary sexual characteristics like underarm hair. And then the center of the adrenal gland makes adrenaline or epinephrine. So when we talk about adrenal insufficiency, what does this mean? This means when the adrenal glands are not functioning normally. So they're not producing adequate amounts of cortisol. So when this happens in the term of primary adrenal insufficiency, this means that the abnormality is in the adrenal gland. And in this case, the cortisol amount that is being made is either low or not high enough. And the ACTH levels are high. That tells us that the brain, the pituitary, is sending a signal, but the adrenal glands are not 100% listening. You may also have heard the term called secondary adrenal insufficiency. So this is when we use this term, we use it when we refer to an abnormality in the pituitary or the hypothalamus, so the control center. So the adrenal gland would be working fine. It's just the brain or the pituitary is not sending the signal. So that is what secondary adrenal insufficiency is. So we will focus on primary adrenal insufficiency because this is a type of adrenal insufficiency that is seen in ALD. So adrenal disease in ALD occurs fairly commonly based on the information that we have so far in the natural history studies, about 80%. It can present in the first few weeks of life with blood test changes or biochemical changes, and a little bit later with physical signs as well. It is a glucocorticoid deficiency, meaning cortisol is not being made in sufficient amounts. Some individuals, particularly later in life, may develop mineralocorticoid deficiency as well and need replacement for that. To the best of our knowledge is right now, but this field is evolving for sure. There's not a clear biochemical marker or a way to predict the onset of adrenal insufficiency in an individual who is at risk. Genetic variations in the ABCD1 gene or very long chain fatty acids do not directly correlate with the incidence of adrenal insufficiency, but there's a lot of work going into try and better understand that. And adrenal disease and neurologic disease are not directly correlated either. Less than 1% of female heterozygotes are expected to develop adrenal insufficiency. And so at this time, childhood screening is not indicated for females who are heterozygotes. But I know there's a lot of work in this area, particularly for adult females as well. So more to come. So why does adrenal insufficiency happen in ALD? The very long chain fatty acids accumulate in those adrenal zones that make cortisol and puberty hormones, and then the adrenal gland is not able to produce enough cortisol. Adrenal insufficiency can present before neurologic changes. And so one of the goals for newborn screen was to identify adrenal insufficiency before an adrenal crisis or before significant symptoms of adrenal insufficiency were to develop so that appropriate treatment can be put in place. Adrenal insufficiency can be managed safely and effectively with hormone replacement, this is steroids, and lifelong replacement is safe. So this is why it's really important for individuals with ALD to establish care with a local endocrinologist, and for children it would be a local pediatric endocrinologist. And depending on where you live in the country, sometimes they're a little bit ways away. But I think really having that member as part of your care team is really important. So what are the symptoms of adrenal insufficiency? So I'll break this apart into two sections. One is chronic symptoms. This would be symptoms that one might see if there's undiagnosed adrenal insufficiency going on for some time. So this is abnormal darkening of the skin or hyperpigmentation. Particularly, we see this in the area of skin creases. So scars, the palm, soles, underneath the arms, elbow creases, gum lines, behind the ear. Can also be weakness or fatigue, loss of appetite and nausea, intermittent abdominal pain. So a lot of these children are first evaluated sometimes with a gastroenterologist or having stomach symptoms evaluated. There can be weight loss, and then less commonly, salt cravings. So this is an individual who had undiagnosed adrenal insufficiency, and you can see kind of over a course of a couple years, the skin became more tan. This was in the wintertime when one may not expect the skin to change. So these are the kinds of things we're looking for: whole body skin changes as well as changes in the skin. This is a picture of an individual who does have X-linked adrenal leukodystrophy and has hyperpigmentation of their skin. And so this happens usually over a long period of time, but you can see the particular areas that we're focusing on, and includes nipples, the tongue, the gums. And then you can see this individual's hand in its comparison to this individual's wife who's of the same ethnic group, and just the difference between that. And that highlights the hypopigmentation, particularly over the knuckles and over all the hand as well. More acute or kind of short-term symptoms of adrenal insufficiency usually occur if somebody has an infection or another physical stress and they have adrenal insufficiency, whether it is diagnosed or not yet diagnosed. And we would see nausea, vomiting, abdominal pain, dehydration, low blood sugar or blood salt, and low blood pressure, sometimes altered mental status as well, along with signs of an infection or physical stress. So moving on from symptoms, we talk a little bit about how do we monitor for adrenal insufficiency. There are a couple of things that I think that are important, and there's a little bit of, we'll share the guidelines that are out there for monitoring, and then there are some more provider-specific kind of things and some logistical things based on where you live and how the hospital systems work as well. So the first is to have an evaluation by a pediatric endocrinologist shortly after the confirmation or high suspicion for an ALD diagnosis. And I think at those visits, it's important for that provider to do a physical exam to look for signs and symptoms of adrenal insufficiency. Oftentimes there are not any, sometimes there are some. There are blood tests that are done to evaluate how the adrenal gland is doing, the ACTH and the cortisol, and we'll talk a little bit more about that. And then education for parents or caregivers about these signs and symptoms to monitor for at home in between visits. And then having regular follow-up with a local pediatric endocrinologist, over time and long term will be really important. So when is the monitoring recommended? So for children under age 2, the recommendation is to have adrenal gland monitoring about every 3 months or so. And then for children that are older than 2, every 4 to 6 months. The reason for more frequent lab tests in the younger age group is that a lot of these symptoms or signs can really be non-specific, meaning it can be from a variety of things. And in younger children, it can be hard to sort out what is what. And so we rely a little bit more on labs. And as kids get older, their ability for them to express more what they're feeling and more signs and symptoms that can be more easily discernible. And so lab testing may not be as frequent. And then having a regular follow-up with a pediatric endocrinologist every 6 to 12 months, and then additional in-between testing if there are concerns about new signs or symptoms that develop. So how do we do the testing? So adrenal gland testing is blood tests. We measure the blood ACTH and then the cortisol. The best time to do the test as much as possible is in the morning, because this is when the body is making the most amount of cortisol, and that's what we want to try and capture. This is less important for young infants because their day-night cycles haven't quite been established, but for older infants, toddlers, morning labs are preferred, and it allows us to measure day-to-day how much cortisol is the body making, and how happy is the body as far as how much it is making, meaning what is going on with that ACTH level? What is the balance of the hormone in the body? In addition to doing morning tests, your your provider, the medical provider, pediatric endocrinologist, may recommend something called an ACTH stimulation test. So this is a test where the individual is given ACTH, that signal from the pituitary gland, and then we measure how much cortisol does the adrenal gland make. So it evaluates how can the adrenal gland respond during stress. And ACTH stimulation tests are typically done in the office or an infusion center, so out of outpatient. And ACTH tests can be helpful when the results of the morning blood tests are not clearly normal or clearly abnormal, and so they can really be informative. And in some cases, they may be part of the initial evaluation for infants, just given the challenges of doing measuring cortisol in infants. So these are the different situations where you may encounter it. In addition to this, sometimes checking the blood salt and blood sugar level are indicated depending on other information. And then really importantly is monitoring growth, so height and weight, along with symptoms. And that often is, in collaboration with the pediatric endocrinologist, as well as the individual's primary care provider who may see this patient more often. So I've shared here from 2018, Dr. Reigelman led a group of pediatric endocrinologists to come up with some consensus guidelines as far as adrenal gland monitoring. This table can look really complex to a parent or a caregiver, but this makes sense to an endocrinologist. And so I just wanted to put it up there as kind of our reference and some suggested guidelines, but it really focuses on those two hormone levels, the ACTH and the cortisol, to help guide what to do next, along with how the child is doing as far as growth and symptoms. So how do we make the diagnosis of adrenal insufficiency? So normal adrenal labs, when obtained appropriately, are reassuring. So as I mentioned, a lot of these symptoms may be from something else. They can be non-specific. And so a normal adrenal function testing can be quite reassuring. Symptoms may not always be present when labs are abnormal. So sometimes labs change first before we have signs, but our goal is to monitor with an appropriate frequency to hopefully pick these things up. Steroid treatment is typically started when blood tests are abnormal, and that is together in consultation with, of course, the pediatric endocrinologist and how the individual with ALD is doing. And symptoms may not be clearly present even in that situation. Further down on the slide, I just have just general parameters about lab tests. Lab ranges are different. And so really going over those specifics with your medical provider is important. But in general, normal adrenal function means that the ACTH and the cortisol are in the normal appropriate range. Partial primary adrenal insufficiency means that the ACTH is elevated and the cortisol may be normal or not, or relatively low. Primary adrenal insufficiency means ACTH is elevated and the cortisol is low. And then secondary adrenal insufficiency, which we won't focus on, but we talked about as an issue with the ACTH signal being set, both the ACTH and the cortisol are low. So how do we treat adrenal insufficiency once it has been diagnosed? So our overall goal in treatment is to restore normal adrenal hormone balance and prevent adrenal crisis. So the individual can grow and thrive. And so we break our treatment down into two main components. One is making sure the body has sufficient cortisol for daily needs, and then sufficient cortisol for physiologic stress to prevent adrenal crisis. And so when we're talking about physiologic replacement, what I mean by is we just give back what the adrenal gland isn't making enough of. And so this is how we decide how much steroid and how to give it is kind of having this principle as our background. So the mainstay of treatment of adrenal insufficiency is replacing the cortisol. And typically in children, this is done with hydrocortisone, typically given 3 times a day because of how long the medicine lasts. And our goal is to provide sufficient cortisol throughout the day. And then there's additional hydrocortisone given stress dosing every 6 to 8 hours for at least 24 hours. And how much is variable, but generally the thought is you want to triple the daily dose to make sure that there is sufficient cortisol around. Some individuals may need replacement of mineralocorticoid or that salt hormone. And so we monitor for salt cravings and investigate further if that occurs. Some individuals may only require stress dosing, meaning their adrenal gland is producing enough cortisol for day-to-day needs, but just need additional during times of stress. So as I mentioned, our mainstay for children is the use of hydrocortisone, typically given 3 times per day. There's various formulations. The tablet is the most common. It can be crushed, chewed, or swallowed. There are also granular formulations, or the Alkindi sprinkle, which can be given on food or directly to the mouth, but should not be dissolved in liquid. And then there are liquid preparations or compounded hydrocortisone. I list it up because there are some individuals who use it. This is not standardly recommended outside of specific guidance from pediatric endocrinologists. Because it needs to be compounded correctly, and there are concerns about if that is not the case. So really being cautious about that is important. Prednisone or prednisolone is another form of cortisol replacement that is used, typically given 1 to 2 times per day. This is an option for adults and also for children who have completed their growth, but also there are many young adults who use hydrocortisone. And so this would be daily dosing for those who need it, in addition to stress dosing. So I've talked a little bit about stress dosing, and I know there's a lot of questions. I'll go over some of the basics. What do we mean by when we say stress dosing? So this is during times of stress, the body needs more cortisol. It supports the blood pressure and blood sugar and the other key functions of the body during that time of stress. So we mean physiologic stress. So this is a fever, temperature over 100.4 is a typical definition, vomiting, diarrhea, surgery or procedure, somebody's getting an MRI under anesthesia or sedation, or if there is physical trauma like a broken bone. It's not necessary for psychological stress like school exams. So we're talking more about stress on the body, physical stress. Hydrocortisone is typically used for stress dosing. We triple the daily dose for at least 24 hours and divide it out in every 6 to 8 hours. I typically recommend that you can take hydrocortisone by mouth if that individual is able to take things by mouth. But if they're not able to take things by mouth, either because there's vomiting or loss of consciousness, that is when we recommend to use the Solucortef injectable hydrocortisone and seek emergent medical care. So for all patients who have adrenal insufficiency, regardless of etiology, we recommend having a care plan. This is one example. There are a lot of them out there, and each endocrinologist kind of has their own. But it's a nice way to have the information about what the daily dose is and kind of how and when to do stress dosing. The other things I've included on the slide, including some form of identification, whether it is a bracelet, a necklace. Some people have wallet cards. There's a lot of options, and different things work best for different families and individuals, but identification. And then I think really importantly, making sure you have Solucortef and are educated by your pediatric endocrinologist or their team about how to administer it. Monitoring growth and development really is a mainstay of how we make sure that we are appropriately treating individuals with adrenal insufficiency and that their doses are appropriate for their needs, but not excessive. And so for children, growth in puberty is a really an important marker for many things, but it can really help us make sure that we're treating in the appropriate way. And so this can be monitored by the primary care provider and the pediatric endocrinologist. An individual who's getting too much hydrocortisone for their needs, for children at least, they will be slowing down in their growth inappropriately. And appropriate steroid dosing or appropriate adrenal function is seen when we see typical growth and development. So it's a good marker. We know that long-term use of glucocorticoid for physiologic replacement really can be safe, but monitoring is required. Blood tests may be needed for individuals who are on hydrocortisone, but this is variable based on the individual and the pediatric endocrinologist. But it is can be helpful to monitor ACTH levels, and then if needed, salt and electrolyte levels. And then monitoring for symptoms of adrenal insufficiency or cortisol excess, as we talked about, are really important to make sure that we're adjusting treatment as needed. So I'll finish up with kind of 4 key points. There are a lot of information that I covered, but I hope that it has offered some insight. Boys with ALD are at risk for developing adrenal insufficiency, and these changes can occur before neurologic changes. And it is most commonly occurring in childhood based on the natural history studies that we currently have. Lifelong adrenal screening is recommended with the goal of identifying adrenal dysfunction before there are symptoms of adrenal insufficiency or adrenal crisis, and establishing care with a local pediatric endocrinologist as part of your child's team is really important. Adrenal insufficiency has safe and effective treatment, and that is in the form of hydrocortisone, typically for children. And then this field is evolving, and so recommendations may evolve as we learn more about the adrenal disease in ALD. And so, stay tuned. I think we will hopefully, as we learn more, be able to better monitor and identify those individuals at risk. Thank you.
Thank you so much, Dr. Shah. How lucky your patients are who get to meet you in person, because this is one of the best presentations I've ever seen. It's so concise, so straightforward. So I'm so grateful for you allowing us not only time with you, but to create this resource. We're going to take a bit of a pivot and focus now on some parental expertise. Sophia Rowland is a constant contributor to the community and a good friend. And I'm so grateful that she really raised this issue, and she's the inspiration for this webinar. So I'm going to hand it over to her and let her share some of her experience, and then we're going to come back to some Q&A. So I just want to note there are folks who are putting questions in the Q&A. We will be addressing them to the best of our abilities in the latter part of this webinar. Sophia, take it away.
Okay, I'm going to do a share screen here. Let's see if I can do it. Okay. So I'm Sophia Rowland. Hi. I'm a newborn screen mom. My son, Yossarian, just celebrated his 2nd birthday. Our family story is pretty standard fare as far as newborn screen stories go. Yossarian was flagged at birth, and we were given the diagnosis of X-linked adrenal leukodystrophy, a disease I had never heard of before. So after getting off that initial traumatic call from the pediatrician, I remember watching a video on ALD Connect's website that really broke down the 3 pathways ALD can take. And as I watched it, perhaps like many of you, I became fixated on the fear of childhood cerebral disease. And as a result, I kind of compartmentalized AMN as something that would happen later in my son's life. And I brushed off adrenal insufficiency, thinking along the lines of, he takes a pill, he'll be fine. So like all newborn screen boys, Yossarian has been monitored with blood work since birth. My family watched over many months as his ACTH slowly went up and his cortisol dropped, and my heart sank. All this time, I was so lasered in on childhood cerebral disease that I let adrenal insufficiency sneak up on me. And it honestly wasn't sneaking up on me that quickly. I was just really overwhelmed. The reality of daily steroids brought me back to that initial trauma of the diagnosis, and it made it all a lot more real. But our wonderful endocrinologist and the community stepped up and helped me through this. And while I came to realize that it wasn't as simple as he takes a pill and he'll be fine, it is all very manageable. So if any of this sounds familiar, then I hope that this presentation really benefits you. We've just learned so much from Dr. Shah and her wonderful presentation. So hopefully all of this will put your mind at ease with this initial part of ALD plus adrenal insufficiency. And maybe it'll just all feel a little less daunting. It's a compilation of everything I've learned with amazing tips and ideas from other families. Dr. Shah talked about this a little bit, but when your child has borderline numbers or is diagnosed with adrenal insufficiency, there's a risk of them going into an adrenal crisis, and obviously you want to be prepared. You should make several kits with emergency supplies and one that is with your child at all times. Needles and Solucortef you get from the pharmacy, Band-Aids, alcohol swabs, gloves, gauze, you can get that off the shelf. But you'll also need printed instructions for how to use the Activile, and I highly recommend one that's easy to understand. And unless you work in medicine, and even then, it's not very intuitive to inject your child with a needle, even if the medicine is life-saving. So have your endocrinologist's office teach you how to do the injection and brush up on from time to time with helpful YouTube videos so that you feel prepared in an emergency. And then the most important tool to have in all of your emergency kits, besides the medication, is a letter from your endocrinologist. In the worst case scenario where you call an ambulance or have to take your child to the ER, you want the letter from your doctor, letterhead and all, stating that your child has adrenal insufficiency, because it's going to save the hospital the time of determining what's going on. And our word as parents won't be taken as seriously as the medical documentation. So think of it as your golden ticket, if you will, in a crisis. The hospital does need that paper stating that your child has adrenal insufficiency. And then, again, Dr. Shah mentioned this as well, having a medical alert bracelet or some sort of medical ID card. The bracelet is ideal. If something happens and you're not there in the event of an accident where you're unconscious, God forbid, an EMT is going to respond to the medical ID on your child's wrist. So here are some examples of what to write. Many of the caregivers in the community I spoke with like the company Real ID because the bands are comfortable and soft, but tricky for toddlers to get off. And then you can also have your local fire department flag your house so that in the event of a 911 call, they know that in your home there's a child with adrenal insufficiency. Other notifications in the car, like seatbelt covers, this very cool headrest pocket, or a decal can help alert an EMT that there's a child on board who needs assistance in the event of an accident. But the bracelet is the most important piece. EMTs may hesitate to inject even with a decal or a seatbelt cover if there's no medical ID. And then you can search by state to see the protocol of your local EMTs. Some states require ambulances to carry Solu-Cortef. Some don't. Some allow EMTs to give the patient their own medicine, and others don't allow that either. This is another reason why that emergency letter from your endocrinologist is so important. So just don't allow yourself to get stuck waiting in the ER to establish that your child has adrenal insufficiency. And then this one's tough. When to start daily steroids? So how do you give your toddler a very bad tasting medicine 3 times a day? The hydrocortisone tablet is meant to be swallowed, not chewed. But this was really difficult to explain to my 1-year-old. When you bite into it, it has a kind of metallic taste that lingers. So here are some of the incredible suggestions and methods other moms have found worked for them. And of course, if your child is able to swallow a pill, have them do that or teach them when they're a little older and seem ready. Unfortunately, for my son, he was just not food motivated and was really good at finding the pill and just refusing to eat for the rest of the day. So we put the pill in a syringe with a little apple juice to liquefy it. I don't want to downplay it because this can all be really hard. For us, it started with my husband and I holding our screaming son down, and it was awful. And I was also crying after each dose, but we buckled in, and after each time we sat my son up and praised him. And over the course of 2 weeks, he started taking the medicine down without a fight. A few months out, it's almost never an issue. I'd just say that being the parent of a child with special needs often requires you to dig deep and find the resilience you didn't know you had. So if you have a similarly strong-willed kiddo, then hang in there. And then on stress dosing, like Dr. Shah had talked about as well, if your child's sick with a fever or vomiting, you're going to be instructed to give them more of their medication more often than usual. And I suggest writing down the instructions that you get from your endocrinologist and taking a screenshot of, any of the info they give you. Because last week, my son came down with COVID and a fever, and it indicated that, we needed to start our stress dose protocol. And it was actually our first time. And in the moment of realizing that we needed to stress dose, I suddenly blacked out and was like, what are we supposed to do? Despite knowing everything that I know about adrenal insufficiency, I had to pull up the documentation and reach out and remind myself of the steps. And obviously our endocrinologist and all of our adrenal insufficiency caregiver friends supported us and assured me that they also black out when it's their child. But I do want to say that he did really great with the medication. He cleared COVID faster than any of us. But I relay this story because it reminds me that knowing all this information is one thing, but actually doing it is another. And the more you know and the more you do, the less intimidating it all becomes. So one thing to keep in mind is you don't necessarily have to tell the elementary school or preschool that your child has ALD, which is pretty hard for anyone who isn't in the thick of it to wrap their head around. You could instead tell them that your child has adrenal insufficiency and the protocols around that. A 504 plan in public schools is highly encouraged. This will help you and your child establish protocols for the school. Our kids might miss school due to extreme reactions to illness or because of medical appointments, MRIs, and they don't need to be held to the same absence standards as everyone else. If you're not sure where to start, contact your school's administrative team and ask about putting together a 504 plan for your child. And don't hesitate to reach out to caregiver support groups, as many families have gone through this process. If your child's enrolled in a private school, start these conversations with administrative teams early. And regardless of public or private school, have clear documentation you can provide. NADF has an adrenal action plan pictured here that you can fill out with your child's specific information. And if you're coordinating teacher training or caregiver support, one tip that I received is when you're demoing how to do the injection, you can use your expired Cellucor-Tef bottles. Okay. In preparing for this webinar, I spoke with many caregivers about their incredible, resilient children. And it was evident talking to all families that these boys go through a lot medically, starting at a very young age. And as the quote on the slide shows, a donut or a treat after a blood draw goes a long way. And the overwhelming advice from parents is to make all these medical experiences as rewarding and fun as possible. Another tip, if you're going through a stim test, which is more involved than a blood draw, is to ask for child life to come and help your child during the process. Regardless of your child's age, child life are trained professionals whose job it is to make your child's medical experience better. They bring bubbles and toys or iPads for older kids, and they can be a great shoulder to lean on for you as a parent as well. And for standard blood draws, depending on where you're going, if you're going to a lab, I found it helpful to ask if there's a pediatric phlebotomist available. They often have someone there, at least with some pediatric experience, who's on staff, so they might work specific days, and it never hurts to ask before you visit. These medical experiences also present a unique opportunity to help your child take ownership of their diagnosis. As they get older, maybe let them sort their own pills, let them be a part of the school meeting over the 504 plan, but mostly try not to let your perception of their experience define their reality. You might be surprised with how they end up feeling about their circumstances. And then I wanted to include some of the organizations and opportunities to find caregiver support. ALD Connect, who is hosting this wonderful webinar, and the ALD Alliance, Adrenal Insufficiency United, and NADF are all wonderful organizations that can help you connect to doctors and peer mentors, educational videos, documentation to learn more about ALD and adrenal insufficiency. There are several groups on Facebook. I've listed a couple here that can help connect you to other families going through similar diagnosis. I made many of my connections through ALD Connect's community call and their annual conference, as well as some of the Facebook groups. And it's been such a huge emotional support to be able to talk to folks living in the same reality. Finding community and connection is really the most important thing I found as a caregiver and parent in this unique situation. And then I just wanted to talk for a minute. Last year, my family had the opportunity to go to the Painted Turtle ALD Family Weekend Camp, which they're hosting again this year. The Painted Turtle Camp is in Lake Hughes, California. It serves families and children with special needs and medical conditions. The camp itself is free to families, including cabins, meals, activities like crafts, archery, swimming. There's a full gym, horses, a ropes course, a pool. And there's also a medical team with nurses available. Many of the camp counselors are former campers themselves, and the way that they connected with the kids was really unique and beautiful. If you're interested, please reach out after the webinar. We'd really love to see more families come out this year. And again, it's totally free. You just have to get yourself to California. There are also 2 other sessions available, not exclusively for ALD, but for adrenal insufficient children and families. And for those sessions, a pediatric endocrinologist from Children's Hospital Los Angeles, who specializes in managing children with adrenal insufficiency, volunteers at the camp, and for the family weekend and for the summer session. They have hydrocortisone on site for emergencies if needed, and staff are trained on administering it. And for the kids only session, they have a nurse assigned to each cabin, and parents will have the opportunity to meet the cabin nurse at drop off. So again, don't hesitate to reach out if you're interested, especially for the ALD family weekend. We'd really love to see more families come out. So I included this slide to give some perspective to any caregivers fearing what their child's future may look like. All the men in the slide have ALD and adrenal insufficiency. Pictured are a high school athlete, a triathlete, a sports writer, mechanical engineer, a YouTuber, and a loving father and husband. Some of them are adults living with AMN, some have gone through transplant for childhood cerebral, and some just have ALD and adrenal insufficiency. And it's tough not knowing how the disease will manifest for our children, but I hope looking at all these wonderful men that you feel more hopeful for your child's future. And then thanks to all the families who helped make this presentation possible and who guided me through my son's adrenal insufficiency journey. I hope this has been helpful to new families. Please don't hesitate to reach out to me or any member of the community if you're struggling to navigate your ALD or your adrenal insufficiency diagnosis. All right.
Awesome. Thank you so much, Sophia. You've put so much time and effort. And again, I think you've really helped to develop building such a beautiful community of parents. I do want to highlight that you've started a new Facebook chat group just on this very topic, because we know that sometimes we've got a burning question and it's 2 a.m. and you're reaching out and you're looking for some friendly advice. So I appreciate so much the effort you've done to put all this together.
Thank you.
And again, the inspiration for this webinar. So with that said, we have so much amazing community involvement. We have been receiving questions. So I am trying to group them. So if I do not repeat your question verbatim, know that somebody else sent us a slightly adjacent question and we're trying to wrap it up. So to our panelists, giddy up. I'm going to start lobbing questions, and hopefully we can get to all these topics. First of all, Dr. Shah, how often is there a standard timeline or time frame for testing ACTH and retesting ACTH? Some people in the comments and questions suggested that they get tested annually. Some people said they feel like other people get tested more frequently and they're concerned that they're not being tested enough. Is there a standard of care or is it something else?
Great question. So for individuals who are diagnosed with adrenal insufficiency and who are on daily hydrocortisone, ACTH levels, our goal is not necessarily to normalize them. And so ACTH blood testing has a role, but my interpretation is that it's usually should not be used in isolation. So it can be helpful. And so that's why I think there can be variation in how it is done. So there's a role for it. And that is pretty consistent throughout how we manage primary adrenal insufficiency for other reasons as well.
Sure. And there's also a more specific comment about what do you think about, or do you have a thought or an opinion on the process of different practices that will continually adjust cortisone replacement based on ACTH as if you're chasing a normal level? Is it necessary to get back to the normal range for non-AI kids? And is it possible?
So it is possible. However, I'll speak from typically when we manage primary adrenal insufficiency, the goal is not to normalize ACTH. The goal is to ensure adequate amounts of cortisol around and normal growth. And so I think, again, an ACTH level in isolation is not typically what we do. It's hard to, I think, answer more specifically than that, but that should not be the only goal.
Sure. Thank you. And so, and again, there are so many questions. One question, are there any side effects or any known long-term side effects from long-term cortisone replacement?
Yeah, great question. And I wish there was an adult endocrinologist here as well, because they can comment more on that. But in general, physiologic, so kind of just matching what the body needs long term. We don't expect, big significant side effects. Our goal is to replace what is going on. But as I talked a little bit about, kind of that monitoring is really important, because what the body needs changes over time. So yes, getting a lot more than what your body needs definitely has implications, blood sugar, blood pressure, metabolism, bone health, all things that are really important. And so really working with your endocrinologist to find that what we call lowest effective dose that's safe and maintains what you need will help minimize those potential side effects. And that has to be balanced with making sure you get enough, when it gets enough cortisol to meet their needs as well. But hormone replacement is safe. I think this is different than using steroids for other reasons that people may use steroids when the doses are typically much higher, and that does carry side effects.
Right. And so conversely, I'm assuming then that there's no real concern about getting hung up on a certain ACTH lab level. If everyone's feeling well, but a number is climbing, should people be concerned? Is it a discussion between a patient and their doctor directly?
Yeah. So I think, yes, it really should be a discussion. I think that watching the trend is important. I think it depends if somebody's getting treatment already, or they are in the monitoring phase, and there's a discussion about if hydrocortisone needs to be started. And so, yes, the trend is really important. And there are some guidelines about clearly normal and clearly not normal, which that's when the blood test really said, but there's a lot of in between. And that's where that conversation is super important, because it's very individualized as well. And to kind of go back on that, I think the question about ACTH and normalizing it, typically if somebody is on steroids and their ACTH goal is to bring it down, they often are getting over-treated with steroids. It's too much. And so it's usually not something that we will aim for as we're looking at the whole pictures.
Sure. And is there a difference in how you treat adrenal insufficiency that maybe doesn't necessarily first show up as part of ALD, but comes after a cerebral transplant? And is there a difference in monitoring that?
Yeah, that's a great question. I think primary adrenal insufficiency, from various reasons, whether it is from ALD, pre or post-transplant, or another reason, autoimmune Addison's disease is another common reason. The treatment and how we replace the hydrocortisone is similar, and how we monitor how effective it is similar. Sometimes there are other health issues or other medications that are being used that may impact how we do things, and so that way it may be a little bit different, but the principles behind the treatment are the same.
Okay. And then we have a whole section of questions about symptoms. One regarding the kind of abnormal hyperpigmentation. Is that something that lasts forever, or does that go away with treatment, or will they always be kind of on the tan side? Curious minds want to know.
Yeah, no, it's a great question. I think that there is a spectrum. For a lot of times individuals who are have been diagnosed with adrenal insufficiency, they've had it for a long time and they're picked up. And with the newborn screen, we're hoping that time decreases. And there's evidence actually showing that we are identifying these individuals much sooner, which is a good thing. And so oftentimes there can be some decrease in the hyperpigmentation. In my experience, just speaking about adrenal insufficiency in general, reverting back to the baseline is much less common for sure, but there usually is to be a decrease.
Sure. And someone had asked about, is dry hands a symptom of
low cortisol?
of
Yeah.
cortisol, or should they seek
Yeah,
professional advice in a different direction?
yeah, it's not one of the ones that we typically think about, and it depends on what else is going on. But yeah, dry hands is one of those. It's many things. So yeah,
Sure.
more medical advice.
And then in terms of regular dosing, there
Yeah.
are, as we discussed ahead of time, because we anticipated some of these questions coming in, there are some questions about some people are dosed twice a day by their physicians, and some are recommended to dose 3 times. And there are other questions based on, are you about the circadian rhythm and attempting to align with that. Is there any set
Yeah. This is a great
schedule?
question, and this is so hydro in children, growing children, our preference is to use hydrocortisone because we get doses that are low enough to meet the needs. Typically, this medicine is used 3 times a day. However, there are some children for whom twice a day meets their needs, and so that's why there is some variation. Um, I think a lot of it is understanding how the day goes and how that individual is feeling. There are a lot of kids who are on twice a day and they have that kind of have some symptoms later in the afternoon. And there are other children that it meets their needs. For young children, because they can't be as verbal and things change so fast with kids in terms of how they feel, our typical practice is to do 3 times a day. But again, there are individuals twice a day hydrocortisone works well for them, and for adults with adrenal insufficiency, twice a day hydrocortisone dosing is more typical. But some individuals are benefit from 3 times a day.
Awesome. And so moving on to the next part of dosing, stress dosing. First of all, I have to say, I wish, or maybe my son wishes, 15 years ago that I was as organized as Sophia is in her rescue kit, and she is 100% right, having a letter from your doctor so that you don't just, one time I got told, I said, he's got adrenal insufficiency, he's in crisis. And the ED said, thanks, Mom. It's our job to determine what he has. You just come in and tell us the symptoms. And I was like, oh, okay, I'm going to bring a letter. So I am glad she recommended that. But I wanted to ask, in terms of stress dosing, we have lots of, there are a lot of nuanced questions about the how and why. If someone can still take cortisone by mouth, do you still recommend that they contact their endocrinologist? Is that an important, or should people just say, I guess I should triple dose? Or, is it too much communicating to tell your doctor if they're in kind of manageable updosing, or only if they're going into an emergency room or needing the injection?
Well, that's a great question. I think it really is dependent between the family and the endocrinologist. Everybody's got their own system and they have different team members depending on, where they how their practice is. And so I think that's an important question to ask. If the person you care for is diagnosed with adrenal insufficiency and needs to be on steroids, how is the best way for me to communicate with you and when? I think typically if emergency care is needed, I think that's an appropriate time to call, or if there are questions. But I think getting those things clear when you meet the endocrinologist, or how to communicate in between visits, is so different between providers. And so understanding how that system works, where you're the person you care for gets care, is really important. So yeah, that's I think very individual specific.
Sure. And then, I know certainly on the newborn screening monitoring phase call, there's kind of a persistent question about, everyone gets to this point of, do we have to, and Sophie, you talked about it beautifully, about making that decision. Is it time to stress dose? Is it time to give the shot? Is there a downside to erring on the side of caution, giving a shot, and maybe it wasn't crisis? Is there hydrocortisone toxicity? Is that should parents be worried that something bad could happen if they go ahead and start stress dosing and it wasn't maybe, a professional would decide something different?
Yeah, that's a great question. So, when we talk about stress dosing, we talk about giving extra oral hydrocortisone, that's pills, and then there's the injection. So, I think to kind of cover, if medication can be taken by mouth, so somebody breaks a bone, for example, but they're okay, they're talking, they can eat, or they have a fever, they can take one, do the oral. If there is vomiting or loss of consciousness, or somebody is just really, you're like, I'm not sure if they're going to be able to tolerate it, then giving the injection is appropriate. However, yes, to that question of, there are criteria about what we consider physiologic stress. There's some variation for some individuals. There might be other situations where that may constitute significant stress. And so, that's a thing to discuss. And so there may be additional things on your list for that. But I think in general, if yes, they remain that criteria when giving oral stress dosing initially and kind of seeing there isn't harm in that sense, it's short term. I think that if it's happening with some relative frequency, I think it's a discussion to have with your primary care provider, your pediatric endocrinologist, to make sure that things make sense and that you're not giving too much. But I think that yes, you feel comfortable to give that, and if you have questions about does this qualify or not, and that's a good conversation to have with your endocrinologist, because illnesses and colds are different for different individuals, so it's an important thing to clarify.
Excellent. Thank you so much. Because again, that is a discussion that, comes, I think we have that, probably every other month on the monitoring call about, a situation, a scenario. Did I do the right thing? Am I going to make the right call? Do you have any generic kind of recommendations about how to be prepared for crisis? Sophia talked about having a kit and a letter. Do you recommend, I don't know, I think there's on the AI United site, they have a picture of an orange and they suggest giving an injection to an orange, to maybe not with the Salucortef, but giving any injection to an orange to try and, do you have any tips or tricks or
Yeah,
anything that might
it's
be helpful?
absolutely. And as Sophia said, it's the information, but when you're in the middle of it, it can be hard. And so being able to have that information in a place that you can access is really important, because you are trying to remember a lot of things. And so that part is important. And in general, yes, if you're thinking, oh, maybe stress dosing is one dose of an oral dose is not harmful, and it buys you a couple of hours, and then you can reach out to your pediatric endocrinology, your team, to kind of get more clarification. So I think that's I hope that's reassuring in terms of, because you want to do the right thing, that can be okay. But yeah, as far as how to kind of be prepared, I think having identification in various forms is important, especially as children get older and they're more independent. I think, yeah, practicing, and people do that in different ways, whether it's with your pediatric endocrinologist and the team there, using an orange, watching videos. There's a variety of ways. For some people, teaching somebody else how to do it is how they practice. And so I think you can think about what may work best for you and the other people that are help care for your child as well.
Great. And Sophia, I was wondering if there was one thing that you had known from the start, or is there that would have been helpful? I'm sure all of this, everything you've learned now and that you've gone out and sought out, is there one thing though that stands out to you that would have either eased your mind or anchored this parent experience? Because it's a stressful time.
Yeah, it's a good question. I say this sometimes on the support call. I come from like a very California granola crunchy background, and so Western medicine was not always like the go-to, and I think that there was this anxiety about what would the hydrocortisone be like for him, and having him be dependent on a medicine. And I think I had my own personal bias, and then once he started the hydrocortisone, just seeing how much better he felt. And again, I was a first-time mom. Like I'd worked with kids, and I was a preschool teacher before this, but there was a change. There was just he changed quickly and for the better. And then even just this last illness, I had to get up at 2 a.m. to give him a stress dose. And I was thinking like, oh my gosh, he's going to be bouncing off the wall. And he wasn't. He took his stress dose and went back to sleep. And again, he got over COVID in like 24 hours. I was still coughing for days. So I think just remembering that like this is life-saving medicine. This is making his adrenals function. And while there are difficult times in getting adjusted to it, once you get adjusted to it, it is very doable. Not to diminish how intense like starting this medication is, especially with a willful toddler. But yeah, and I think that, you had shared your story about being brushed off at the ER. And so knowing that and the anxiety I had about that, and making sure that we had that emergency letter in the kit, that really does give me a lot of peace of mind. It's in all of our kits. It's in a seatbelt cover thing. Yeah, just being prepared to the level that you as a parent can, feel comfortable with. And our like decal and seatbelt covers and medical bracelet, it does give me peace of mind if there was an accident, even if I'm driving 5 miles an hour anyways. So.
Well, that's great. So I have to say to anyone watching this, either recorded or live, this will be on our YouTube channel. Some of you are seeing this from our YouTube channel or our website eventually, but really I recommend going back and watching these slide decks. There's so many good resources and references and information. I know, especially the one that says what towns, states, counties have different protocols about emergency vehicles, carrying cortisone and Cycortef, because I raised a child for 15 years, lucky enough to be in a state where every ambulance rides with Cycortef. So I maybe didn't carry so much around when I was about and around because I knew it was on every ambulance coming around. But it's good to know. It's good to know when you travel, etc. So yeah, I just want to really thank you genuinely both. To the folks whose questions I didn't quite specifically get to ask, we're going to be sending them to Dr. Shah, and we'll try and connect you. To the folks that are wondering questions about different experiences and child life questions and how can we make these kind of potentially traumatic health events fun, and really part of just a normal family life experience. I encourage you to not only look at Sophia's references, but also join some of the chat groups, come to the monthly call. And we also have, we had a webinar a few years ago by someone from Child Life, so you can look up that webinar as well. But with that, as a reminder, thank you all so much for taking a weeknight in January to come and chat about this. Dr. Shah, thank you so much. I feel like I've been in this, I've had a child with this, well, now he's an adult, and I feel like I understand it even better. So I'm so grateful for your time. And Sophia, again, you are the inspiration for this. And it's been amazing just, to watch your whole transition and to watch Yossarian go from fighting this to being like cool Cali boy with AI, right? So with that as a reminder, if you have any questions, concerns, about what we talked about tonight, this is an opportunity to take those questions back to your own provider and discuss it. And as always, seek a second opinion if you don't like the answer you're getting, but also know that, endocrinology is really an art form, and Dr. Shah is a talent. So, everyone's got something a little different about how they treat, but hopefully it's something you're working out with your individual treatment coordinators. Thank you all for being here. Thank you to ALD Connect. And we look forward to participating with you more in the new year. Be well, everyone.